Chris is a medical physicist at South Australian Health with expertise in radiation detection and radiation physics. He's on the ACPSEMR Safety Accreditation Committee and collaborates with both University of Adelaide and University of South Australia on applied machine learning for cardiovascular health and cerebrovascular disease.
Thank you very much for the kind introduction. Today I'm going to be talking to you guys through the background and current status of risk prediction in cardiovascular and cerebrovascular disease. By accurately and reliably predicting the probability, severity, or progression of cardiovascular disease, preventative treatments can be used before serious disease outcomes occur. These treatments provide much greater morbidity and mortality benefits to patients and are much more cost effective than the invasive measures performed after a major event. No conflicts to declare, and some of the work displayed is subject to the following ethic approval. Medical research of coronary disease risk is a mature field, and as such, we have a relatively good understanding of what should be used in machine learning models to predict coronary disease. The figure on screen is a 2016 systematic review by Damon et al., which looked at the frequency of 100 predictors, which we would use as input features, in the development of 363 different coronary disease risk prediction models. So there's quite a lot of options out there. As you can see, 7 predictors, which are up on the screen, and they're the ones that we would commonly think of, are used much more often than the remainder. And although one model used as many as 80 of those risk predictors on the screen, the median was just 7. So, thank you. Epidemiologic analysis, just trying to move this out of the way, of input data such as this becomes how individual CVD risk is predicted. But without machine learning, the predictors that we've got are pretty simplistic calculators. Further, as the authors highlight, none of the reviewed publications use any data from Africa. So that's a pretty significant sampling bias in the model's development, whether it's a machine learning model or not. So here are some examples of some non-machine learning CVD risk prediction. So I thought I'd go through what we've got before we look at where we're going. A really common example is the Framingham score. It's an empirical model. It's proved useful over many, many years. It's very simple to use, cost effective. You know, it's essentially free on a website. But they are very limited in their application to any one individual because these are developed with populations in mind. Particularly disappointing given these are my actual values. So that is my personal Framingham score. Here is a slightly more complex one, so we're taking things a little bit further. This Euro score is actually used in the prediction of adverse outcomes following cardiac surgery, or prior to cardiac surgery, sorry. This is the Euro score 2 version that I've got up on the screen. The downside here is the model needs a lot more information, and the information that it needs is a bit more sort of medical in nature, so it doesn't lend itself as well to a publicly available calculator, and it should really be used by, obviously, medical professionals. The next one, which was already spoken about today, and I assume will be spoken about again, is calcium scoring. So one version is the Agatston score, but generally referred to as calcium scoring. It's a relatively patient-specific model of risk, and it's obtained from analysis of cardiac CT imaging. So the score of an individual lesion is calculated from its density and area, although those models have been extended to include, you know, lesion volume or lesion mass. And the total patient score is the sum of all lesions. Although it's a mature and proven method for risk prediction, because it's been around since about the 80s, more recent literature shows that composition determines plaque stability rather than simply total plaque size, which was a conversation I was having earlier this morning. The presence of these vulnerable plaques is a strong predictor of individual patient risk, but it's laborious to assess manually. Fortunately, compared to other tools for analysis of other vascular regions, ML tools for coronary plaque analysis are relatively advanced, as I'll show throughout the talk. 2 things I expect will be discussed in more detail, being aware not to take everybody else's talks, is the ability to map vessels and the ability to accurately segment both lumen and pathology. Both are the basis from which a more patient-specific risk prediction can be created, and machine learning tools like AthroPoint and Athromatic are already on the market for doing this. The physiologic significance of an individual coronary plaque can be assessed using something called fractional flow reserve. A minimally invasive procedure requires a dose of blood thinners and adenosine to elevate blood pressure before a pressure wire is inserted from the femoral or radial artery into the coronary area of interest to measure flow pressure immediately proximal and distal to the lesion. This allows cardiologists to determine how disruptive a plaque is to the blood supply. Plaques with an FFR less than 0.8 have a clearly shown disruption to blood flow and are therefore posing an increased risk of major event. The Siemens CFFR heart flow tool performs segmentation and model-based prediction of FFR from a standard cardiac CT, as well as avoiding the risks associated with anesthetic, radiation exposure, infection, and adverse medication response. CFFR avoids errors in plaque risk assessment, which can be seen in small arteries, and it provides a complete assessment of the whole coronary tree rather than only targeting specific vessels. Here is something that was spoken about in the recent talk. This is a systematic review that we published recently where angiographic FFR is the gold standard against which any machine learning tool is compared, and routinely perform CTs provide the training data necessary to develop the machine learning tools. This is highlighting studies that perform validation of the CFFR, so the Siemens platform. And those slides, the studies you can see in yellow there, are ones where someone has either validated an in-house machine learning model against the Siemens platform or validated the machine learning, the Siemens platform using invasive measurements. But without these readily available gold standards, the developed models become novel to clinical management and their adoption becomes experimental. This obviously leads to clinician hesitancy and slower progress. As you can see from this table, this leads into what was spoken about earlier. You can see that the results that are reported are fairly inconsistent, and the number of data points can be a patient, a lesion, or an artery segment. So the comparison between different works being published in this field is quite inconsistent. A large data set's obviously desirable. I think it's a truth universally acknowledged that we need more data in science, and it's always a good thing. But for good machine learning risk prediction, the data needs to be structured and clean. And by that, I mean labeled correctly and absent any data that doesn't belong. The last requirement is that particularly important, and that is the information is representative, so containing all the population that you're interested in. Risk prediction from a statistical is a statistical extrapolation. But if the prediction is made from a model that was developed using data that does not represent the person that the prediction is about, describing risk prediction as a guess would probably be more apt. Cultural, dietary, lifestyle, and genetic factors were all listed on the earlier slides. And so it's important that we have data sets that have a representative sample of all people across all of those factors. And obviously that's quite ambitious. Otherwise, patients risk incorrect care. The CFFR platform is one example where it sort of circumvents these requirements by using synthetic coronary trees. So they were algorithmically developed based on flow dynamics and a standard coronary tree to, as close as possible, capture all possible combinations of a coronary vessel combination. It's about 12,000 total vessel types that were developed. A clearly defined prediction endpoint is used to define the risk of interest. So what is your machine learning model actually trying to do? As you can see in this slide, OCT is useful for identification of thin cap fibroatheroma, which is a particularly unstable plaque type. The presence of a thin cap fibroatheroma is a binary risk factor. So is it there or is it not there? Which could be expanded to the probability of an identified atheroma rupturing, which is obviously something we're very interested in, or extending it all the way out to a 2017 publication from Motwani et al., where they looked at using FFR, calcium score, and Framingham risk score, the one I had up previously, to predict all-cause mortality, including cancer and everything else, which is a bit of a novel application. The American Heart Association and others, but largely them, have spent several decades advocating for the standardization of terminology, imaging view, and treatments in cardiac care. Although it was not done at all for machine learning or with machine learning in mind, it's greatly benefited machine learning, especially compared to other vascular diseases, which I'll talk about in a second. Secondly, the data sets, which was already mentioned today, used for many of the groundbreaking cardiac studies are either publicly available or semi-public behind an email registration and an expression of interest. This was not done with machine learning in mind. So the first Framingham risk tables were collected in 1973, and they used a cohort population from an examination that started in 1948. But this trend has continued with both epidemiologic and imaging data available from many of the largest and most influential cardiac studies, which is relatively uncommon in healthcare. Here's an example of it all coming together and being put into action. So the authors have accessed imaging from 20,084 different patients. The data includes different makes and models of CT, each of varying ages, collected from different hospitals, different locations, analysed by different specialists. Largely, it's an indiscriminate population, except for the text is a little small. The NLST, which is the bottom left one, which is the American National Lung Screening Trial, which is obviously a subset of patients that are at an increased risk of lung disease. Over 5,000 of these 20,000 patients were manually segmented by different clinicians, which minimises any single practitioner's bias. The current practice of using the EHR, or electronic health record information, to empirically predict risk was also repeated. It improves the adoption of the new approach by establishing it first against the old. Several patients receive multiple examinations in a day, which check the test-retest analysis, and further uncommon, the entire code is available in full on the Harvard website for download. So at the end of all that work, an independent prediction score with an adjusted hazard ratio of 4.3 was developed. So really good, promising results for cardiac risk prediction. Strongly recommend anyone that's interested look up that paper. It's Zalesnik in Nature Communications. So that was an example of it being done well when everything sort of comes together. Here's an example where it doesn't quite happen. It's not quite universally the case that we're doing well in vascular disease. So structured nomenclature and large public databases don't exist for other regions. Peripheral vascular disease models, as far as I'm aware, happy to be corrected, but I couldn't find any empirical calculator for risk prediction of peripheral vascular disease. And the tools that are used in cerebrovascular disease is limited to the NASET or the ECST criteria. Excuse me. The current practice is to use ultrasound to measure the plaque intrusion with a ratio of narrowing versus unnarrowed, using to predict patient risk. Recent studies, and this will sound like deja vu, have shown that plaque volume gives a better indication, or percentage hard and soft plaque, which is exactly what was discovered in the coronary vessels previously. It's just now been extended to the carotid disease. Unfortunately, invasive plaque measurements, so you won't find a neurologist out there that's willing to put a pressure probe into a patient that is actively stroking. It's just not done. So you don't have that same sort of gold standard invasive clinically obtained risk prediction that you can then compare your model to show that it's working. Similarly, machine learning assessment of ultrasound imaging for carotid disease is something that has been done, but it's not routinely performed at the time of stroke. It's not routinely performed before stroke occurs, so you only have a data sample bias of patients that have had a known stroke, which obviously limits model development. And it's also prone to inter-operator variation. Excuse me. Here's some unpublished work that's currently in progress, looking at machine learning quantification of carotid disease and automated calculation of that NASET narrowing criteria. The risk associated with an individual plaque can't be determined, as I said, until both vessel and plaque have been segmented. So this is a very early step of developing a new model to apply to carotid disease. But without that FFR measurement or a surrogate thereof, the clinicians disagree quite spectacularly. And these are all very advanced, 20+ year experienced clinicians in 3 different fields. The hope is that this can be resolved and the data can be used to then train a much larger data set of a weekly supervised carotid plaque quantitation tool applicable to CTA. So CT is the standard imaging treatment for both stroke patients and stroke mimic patients. So people that come in with like TIA and migraine and things like that. So in summary, data availability and code transparency encourage collaboration and help to drive ML forward. It should always be balanced against the ethical considerations. Good CVD risk prediction needs a large, structured and representative data set, a clearly defined prediction endpoint, a gold standard that is ideally obtained during clinical practice, and a reference or benchmarking data set. Although situationally useful, many empirical risk calculators should expect to become largely supplanted by machine learning tools in the coming years. Machine learning tools are likely to have the capacity to consider many more risk factors and make much more strides towards individualized predictions. Cardiology has been pushing for data standardization for a long time, before and unrelated to widespread machine learning. But this is not present in other fields, and having it has really helped cardiology adapt towards machine learning-based risk prediction. Outside of the coronary vessels, machine learning cardiovascular risk prediction is still in its infancy, mostly due to these practical limitations that we've discussed. Thank you very much.
Excellent. Do we have questions? Yes, Louis.
Thanks. Really nice talk. Really great kind of way to go, I guess. What do you think has been the big success story in having the standardization in the areas of cardiovascular imaging that you have had? And I guess, how do we push that out to other areas where we really need it?
I got a first-hand crash course in this early on in my PhD, where I got invited to sit in on the stroke patient review meetings. So you've got a table of neurologists, neuroradiologists, interventional neuroradiologists, and they basically identify the stroke and discuss what was done and whether it could be done better. And sitting there and watching, you know, hundreds of years of medical expertise argue over which vessel, and they agree on where it is, but they don't agree on which vessel it is that actually caused the stroke. I think that seems so fundamental. And I know we have cardiologists in the room, and if you talk to them, it seems so obvious that we have names for segments, so we're all talking about the same thing. I think that is probably the basis. You can't build a house on wet sand. So talking about the same segments of vessels and the same regions of brain or liver or lung or wherever it is you're dealing with, and making sure you're speaking the same language, I think that is a really obvious thing that a lot of people don't put any time into. So I think when you're talking about risk prediction, especially, not when an event's happened, but where you think it's going to happen, knowing where you're talking about, I think is a really, really important first step.
Question over here.
Hi, I really liked your talk, thank you. I've heard, not just from you, that there have been issues, obviously, in gathering data. You mentioned that there's an underrepresentation of patients that based in Africa. And then I think you also mentioned that some of the data was coming from high-risk patients, obviously because the tests are done on those patients for a reason. It's a big problem, but what are your thoughts on how we can get closer to the end goal of good data?
That is a big question. That is a very, very big question. So I don't know that I can offer a lot of solutions, but I can probably help explain the problem, break the problem down a little bit, which I guess is kind of the first step. First of all, healthcare access is not equitable, right? It hasn't been equitable anywhere. And I think machine learning is a good thing because it's something that most people that are active in machine learning are thinking about from a slightly detached, objective standpoint of like, I want my data to be good, but these data are all people, right? So by making our data representative, we're then pushing to make healthcare equitable and representative and accessible to everyone. So there are minorities in healthcare access in every healthcare system, right? No matter how you look at it. People just have cultural or social or economic predisposition to avoid healthcare. So I think you also have, and it's not as bad in hospitals as it is in particularly private imaging. So calcium scoring is done in private imaging, right? And the positive hit rate is quite low compared to what it would be in some other settings. So you're going to have a imbalance of positive versus negative, which has already been mentioned, and you're going to have an imbalance of people that tend to seek out healthcare versus people that tend to not seek out healthcare. I think the best thing to do is to use your minimum your minimum frequency class to determine your total data set. So, and I'm stereotyping here, but I know in America, the healthcare system is quite inequitable. And so African Americans tend to access healthcare less. So the total number of African Americans you have is the total number of non-African Americans you are allowed to include in your data set. So be limited by your minimum sample, whereas you could probably get access to 3 or 4 times as many Caucasian people. Don't. I know it's tempting, and I know I've said more data is better, but when the data is not representative, you're just inherently perpetuating a bias that needs to be stopped. Cool.
Great.
Thank you very
Another
much.
Question? Yeah, speak up. Okay. I might just repeat. What's your take on generated models to create data?
So this is particularly in reference to the 12,000 trees, coronary trees that we use for the training the heart flow platform that Siemens used. Yeah, there's some really interesting papers on that stuff. So if it's something you're thinking about, I think it's probably good. It doesn't consider some things that are like when you actually put a patient on a bed and do a scan, the tree that you see is going to be slightly different to what you would get if you, again, what was already discussed, this idealized perfect version. In healthcare, you never get it, right? There's going to be motion artifacts, and there's going to be they'll have a metal implant that causes an artifact across the implant, or, they're a really large patient and you've got photon starvation through the coronary tree or whatever. And those kind of things aren't really simulated from what I can read from the Siemens platform. So it's kind of a balance in that if you don't use real people, you don't have perfect representation. If you use synthetic people, you don't have perfect representation. So it's which compromise are you willing to make for your specific application? And it would depend on what you were doing and how hard your data set was. So the professor previously talked about how ECG data is really easy to get compared to EEG data. So if you were doing it with EEG data and you wanted to synthesize, it might be more justifiable because it's practically limited. So for those contouring examples that I had, convincing a neurologist to sit there and contour when it's not part of clinical practice, they don't do that normally. And it took him like 24, 25 hours. He doesn't have 25 hours to throw away casually and do that. So synthetic data might have some value there. But I think if you don't look at what's actually happening in the real world, your data is pretty flawed intrinsically, no matter how much of it you have.
Right. Other questions before we move on? Nothing online? All right. Then thank you so much again, Chris.